Hello everyone. Today we'll be talking about assessment of myocardial viability. So left ventricular dysfunction remains one of the best prognostic determinants of survival in patients with coronary artery disease. It was originally thought that the dysfunctional myocardium after infarction was irreversibly damaged. However, it was later recognized that some of the involved tissue remained viable and contractility may be restored with revascularization. So what we thought initially was that ki myocardium, which is there whenever any myocardium is get damaged due to infarction, it was thought initially that it is permanently damaged and it cannot be reversed. But later on, with found that when you do revascularization, that means whichever the coronary artery is blocked, if you do repair of that or you open the vessel or maintain the circulation, the some of the tissue may have have regained its functions completely. So whenever there is an ischemia occurs, that is coronary blockage, whenever there is occurs, so there is initial period is called as from the occlusion to 20 minutes. So is a period when there is the heart goes into either stunning, preconditioning, and there is no necrosis. So necrosis does not occur till even though the coronary artery is completely blocked or 100% blocked to the myocardium, it's still preserved up to 20 minutes without any necrosis. After 20 minutes, there starts the necrosis. So initially, the subendocardium gets necrosed, and slowly the necrosis progresses from the mid-myocardium, and epicardium, and then near transmural infarction occurs. So it is an irreversible injury. So once this necrosis occurs, this part you cannot save. Whatever the procedure you do, then you do is to save or salvage the remaining part of the heart. After a myocardial infarction, the myocardium will usually demonstrate one of the five pathophysiologies. So one myocardium may have either a normal myocardial perfusion and function, or maybe in myocardial ischemia, or myocardium may be stunned, or maybe myocardial hibernation or non-viable infarction. So I will go through it one by one. So again, after coronary artery disease, the heart may either go to ischemia, stunning, hibernation, necrosis. So, prompt reperfusion or presence of lateral vessels and intact coronary microvascular function may preserve myocardial perfusion. So, even though there is a blockage or completely coronary occlusion is there, if there is a presence of collateral circulation or if there is any intact coronary microvascular function, if the microvascular function is preserved, that may preserve the myocardial perfusion. Coming to myocardial stunning and myocardial hibernation. So, myocardial stunning is a reversible state of a regional contractile dysfunction that occurs after a transient ischemia without ensuing necrosis. That means that the heart is not going, the myocardium is not necrosed here. The heart is only in the shock and it has just stopped moving. The regional contractile activity has been very much reduced, but the myocardium is viable. It's alive, but only the movements have been stopped. This generally is a protective mechanism so that the energy can be saved for preserving the myocardium. So myocardium gets into stunt. It's a reversible state. That is, if you clear the blockages or do revascularization of the vessel, the muscle will start functioning normal again. So myocardial stunning is believed to play an important role in persistent contractile dysfunction seen in acute MI patient after successful reperfusion. So even after you do reperfusion, up to some time there may be the heart will be remain in the stunt position and later on it develops the contractile activity. In general, myocardial perfusion is normal and function recovers relatively quickly. Myocardial hibernation is a state of persistent left ventricular dysfunction. So, stunning was a case of acute occlusion, and this is myocardial hibernation, which occurs in a state of persistent left ventricular dysfunction that results from chronically reduced blood flow. So, acute blood flow will lead to stunning, and chronically reduced blood flow leads to this one, or maybe repetitive stunning without infarction. So, a downregulation contractile function at rest is thought to represent a protective mechanism to reduce the myocardial oxygen requirements and ensure myocyte survival. So, what happens is whenever there's a chronically reduced blood flow, so there is a downregulation of contractile function. As I said, that the heart myocardium tries to compensately save the myocardial tissue. The body tries to save the myocardial tissue by decreasing its movement. Whenever there is movements are less, there is decreased myocardial oxygen requirement, and thus myocyte can be maintained and survive. When severe cellular hypoperfusion and damage occurs, only cellular function that is essential for survival, such as membrane integrity, is preserved. So during that stage, what mainly they try to maintain is only the membrane integrity is maintained. The rest of the function goes into in the rest state. Stunned myocardium, you can see here acute ischemia when there is decreased perfusion, so there will be decreased function. And after the relief of ischemia, also you have restored the perfusion here, but the function remains low for some time, but the tissue is completely viable, and this is called a stunned myocardium. Hibernating myocardium is a chronic condition where there is decreased perfusion, decrease function, but the viability is maintained. If there is severe and prolonged ischemia, which leads to necrosis, can lead to myocardial scarring. Whenever there is necrosis, that is irreversible damage which cannot be changed. Myocardial stunning, as I said, there is a spontaneous recovery occurs within days to weeks, whereas in hypernetic myocardium, after revascularization, the recovery occurs in weeks to months. Non-viable myocardium. If a myocardial perfusion is not restored, irreversible myocardial necrosis can occur. And that goal of viability testing is basically to determine if a large portion of dysfunctional myocardium is non-viable, in which case risk would likely outweigh benefit of revascularization. So why this phase is important, the non-viable myocardium, why it is important is that which we are trying to say is that if the myocardium is already dead or very much necrosis there, so there is no use of doing a revascularization in that vessel. So even if you open that vessel, already the myocardium is dead or necrosis, there will be no use, but the risk of procedures will be high and patient may lead to unnecessary procedure and procedure related risk may happen. So that's why detecting this myocardium viability before doing any procedure, coronary procedure, is very important. So what are the general pathophysiological principles underlying the imaging of viable and non-viable myocardium? Viable myocytes are generally characterized by preserved energy conversion by mitochondria and maintained membrane function and action potential. So membrane integrity is maintained and also energy conversion by mitochondria is maintained. Therefore, myocardial viability may be identified by preserved electrical activity. So there will be preserved electrical activity. ECG Q waves on the surface ECG are however relatively non-specific. So sometimes ECG, if there is a Q waves are there's a deep Q waves, that is if the Q wave depth is more than 2 millimeters on surface ECG, that is called as pathological Q waves. There generally denotes that the viability is not there, but it is not very much specific. It can be seen in other conditions as well. Next is membrane function. The function of the membrane function is explored by whenever we want to assess the function of the membrane is assessed by the thallium test, and mitochondrial function is assessed by the 99 technetium based Sestamebe scan. An active contraction is a definite marker of visibility. So suppose if a myocardium which was not moving, and if you give a drug which has increased the contraction like dobutamine, if the contraction is being maintained, that means the tissue is viable. Dysfunctional segments at rest may or may not be viable and frequently require further assessment. So let's go through one by one. Another feature of viable myocardium is that resting perfusion is generally preserved. The perfusion is generally preserved or only mildly reduced, and that hibernating myocardium displays preserved metabolism. So metabolism you can check by using the PET scan, and the perfusion can be checked by using the what is called a SPECT, that is a single photon emission computed tomography. A final method for detecting myocardial viability is demonstrating the absence of myocardial necrosis. So if there is no necrosis of myocardium, if you can demonstrate that, that means the tissue is viable. And this is done by the gadolinium enhancement or using cardiac MRI. What are the pathophysiological principles used to detect viable myocardium? So any tissue is said to be myocardium is said to be viable if it has presence of electrical activity, if it has preserved membrane and mitochondrial function, if there is presence of contractile reserve, preserved metabolism, or if there is absence of myocardial scar, that means the tissue is viable. Myocardial viability testing. There are 7 features in it. So you can do it either by ECG, 2D echo, contrast echo, dobutamine stress echo, cardiac MRI, SPECT, and PET. We'll go through it one by one. Coming to ECG, how can you say from ECG that tissue myocardial viability is maintained or not? If the tissue is viable, myocardium is viable or non-viable by ECG, there are a few factors which you can go. ECG is an initial tool in evaluation of viability. Generally, if there is absence of pathological Q waves, so if there is no Q waves are nothing but, I said before as well, the Q waves, the pathological Q waves is that whenever the Q wave is more than 2 millimeters depth, if it is there, that means generally it means that the tissue is not viable. So if there is no pathological Q waves, that means the tissue is generally viable. But Q waves are not specific because these are found in other conditions as well, like myocardial hypertrophy, WPW syndrome, and rarely hibernating myocardium. But the presence of Q waves along with the other complementary markers, it can be useful in determining myocardial viability. Next important thing is the R wave height in lead V3. So in ECG V3, if the V1, V2, the chest leads contains V3, if the height of R wave in V3, if it is less than 3 millimeters, then it is found to be 90.3% sensitive for detection of non-viable myocardium. That means the tissue is said to be non-viable if the R wave height is less than 3 mm. because R wave generally denotes the myocardial contractility or ventricular contractility. So if R wave height if it is less than 3 mm in lead V3, it means it is non-viable. But the specificity of this is less, only 25%. Another important thing is sum of R wave height in all precordial leads. In all precordial leads, that is V1 to V6, you should do addition of all the R wave height. If this R wave height in all precordial leads is less than 28.5 millimeters, the sum of R wave height in all precordial leads is less than 28.5. It has sensitivity of 93.2% and with a specificity of 25%. It's coming to 2D echo. 2D echo in assessment of myocardial viability. It is found that end diastolic wall thickness, if the end diastolic wall thickness, if it is more than 6 millimeter, has a sensitivity of 94% with a specificity of 48% for detection of myocardial viability. So that means if the end diastolic wall thickness is less than 6 millimeters, less than 5% will be viable. If it is less than 6 millimeter, it means that viability is not there. Coming to contrast echocardiography. Myocardial contrast echocardiography evaluates myocardial microvascular integrity. Viable myocardium has preserved microvascular integrity. Intravenously injected bubble contrast agents leads to contrast enhancement of dyssynergic but viable myocardial segments that can be detected with echocardiography. Generally, non-viable myocardium which will not show any significant enhancement with bubble contrast due to distortion of this coronary microvasculature. Because all these microbubbles enters into the coronary microvasculature. If the microvasculature is already blocked, if it is not there, there will be no enhancement of the myocardium occurs. If there is no enhancement of the myocardium with the bubble contrast agent, that means that is non-viable myocardium. The contrast echocardiography uses intravenous microbubble contrast. Microbubbles are inert gases. They behave like red blood cells, and if there is normal or patchy perfusion, it is viable. No perfusion, that means it is non-viable. So you can see here the tissue. You can see here there is no perfusion in this part of thing, and that should to be non-viable part. You can see here. Coming to dobutamine stress echo, it is an important test in assessing of cardiac viability. Before going to the dobutamine stress echo, we should know what is the categorization of wall motion. So categorization of wall motion is defined as either this is labeled as hypokinesia, akinesia, dyskinesia, and scar. Hypokinesia is defined as preservation of some degree of thickening and inward motion of endocardium during systole but less than normal. So hypokinesia means there is the name itself denotes that is decreased movement as preservation of some degree of thickening and inward motion of the endocardium. So whenever the heart contracts, whenever during systole heart contract, the muscle get thickened, and as well as there is inward motion of the myocardium. So if some degree of that is preserved, it is called that. So it has been arbitrarily defined as if it is less than 5 millimeters of endocardial excursion, that is endocardium is moving inside by less than 5 millimeters. Less than 5 millimeters, if it is there, then it is called as hypokinesia. Akinesis is defined as absence of systolic myocardial thickening and endocardial excursion. So there will be no thickening during systole. There should be thickening of the myocardium. So there is no thickening of the myocardium, and also there is no endocardial excursion. That is, endocardium is not coming inside, or movements is not there in akinesia. Dyskinesia is most extreme form of wall motion abnormality and is defined as systolic thinning. So generally during systole, the muscle gets thickening, but if there is systolic thinning, and during systole, if there is outward motion, normally there is inward motion of the myocardium. If there is outward motion, if it occurs, is called as dyskinesia. A left ventricular segment that is thin and highly echogenic suggests the presence of scar. So for dobutamine stress echo, the protocol is patient is prepared for standard stress testing. Intravenous access is obtained. You take digital images record. So baseline images you will take. Then dobutamine infusion is started at a dose of 5 micrograms per kg per minute. So dobutamine is an inotropic agent. So if there is any tissue is viable and all, the contraction of that part will increase. So the infusion rate is then increased every 3 minutes. You will check, and infusion rate is increased from 5 micrograms per kg to 10, 20, 30, and 40. Low dose images are recorded either 5 or 10 micrograms per kg per minute. Atropine can be given during the mid and high dose stages to augment the heart rate response. It is like a stress test, so you have to increase the heart rate also to check like further response. So Coming to the responses, so at rest, if the tissue was normal at rest, that means the thickening was normal, the movement was normal during systole, and if the movement is becoming hyperkinetic, that means normal. So dobutamine is increasing the contractility of that, so that's why it is causing hyperkinesia. So at rest, if it is normal, and during stress, if it is becoming hypokinetic or akinesia, that is decreased movement or complete absence of movement, if occurred, that means interpretation is ischemia. At rest, if it was akinetic, and also after dobutamine, also if there is no movement coming to that, that means the tissue is already infarct or dead or necrosed. At rest, if it was hypokinetic, it becomes akinetic or dyskinetic, that means the tissue is again ischemic or infarction. Or if that rest, if it was hypokinetic or akinetic, and with the stress, that is dobutamine, if it is becoming normal, it means the tissue is viable. So you can see there is biphasic response to dobutamine stress. There is you can see at low dose dobutamine and with peak dose dobutamine, there is reduced systolic thickening at rest, increment with low dose, and deterioration at peak dose in the lateral wall. But the lateral wall, you can see that first low dose there is increased movement is there, but with higher dose again there is completely akinesia of this part. What are the endpoints and reasons to terminate the dobutamine infusion during stress test? So you're doing a stress testing now. So what are the endpoints when you should stop the infusion? Is that so? If the patient has reached the target heart rate of 85% with no significant changes, then it means that the patient has reached the endpoint, and you should stop the dobutamine infusion. If the patient during the dobutamine develops a significant angina or classical angina, you should stop the test. That itself denotes that the test is positive. Recognition of a new wall motion abnormality. So there was a normal movement before and after the dobutamine. If you see in any part of the echo or myocardium, if there is new wall motion abnormality, or if there is decrease in systolic blood pressure of more than 20 from baseline, and patient develops any arrhythmias, atrial fibrillation or non-sustained VT, or limited side effects or symptoms, then also it is called as you should stop the test. ECG evidence of ischemia is less reliable during dobutamine infusion than it is during exercise testing. Normal exercise testing, generally the ECG changes are very much important, but neither ST segment depression or nor elevations during dobutamine infusion is significant, because dobutamine itself is known to cause ST segment depression or ST elevations cause. So any ST segment depression or elevation occurring during the procedure in the absence of any wall motion abnormality is not a indication to stop the test. Safety of dobutamine, because of the short half-life of dobutamine, if indivisible ischemia can be readily reversed, you can actually reverse it through termination of the infusion. If you stop the infusion, the ischemia can be reversed. In severe cases or when the ischemic manifestation persists, a short-acting intravenous beta blocker can be given. You can give a short-acting intravenous beta blocker can be given, such as metoprolol or esmolol is effective. The most common side effect associated with dobutamine is minor arrhythmias, such as premature ventricular contraction and atrial arrhythmias. Non-sustained ventricular tachycardia occurs in approximately 3% of patients. What are the contraindications for dobutamine stress echo? There is no absolute contraindication. Unstable patients are those with uncompensated heart failure for unstable angina. Dobutamine echo has been safely performed in patients with recent MI, extensive left ventricular dysfunction, abdominal aortic aneurysm as well. Next, coming to vasodilator stress echo, it is similar to dobutamine, but where dobutamine directly causes increase in the contraction of the myocardium. Vasodilator stress echo, what does it do? Is this vasodilator, such as dipyridamole and adenosine, have been used. So what does they do is that whenever there is a coronary occlusion, one of the coronaries is blocked. If you give vasodilators, what will happen is the normal coronaries, what will happen then, there will be increased perfusion in the normal coronaries where there is no resistance, but so there is something called as coronary steal phenomenon. So this agents create maldistribution blood flow, that is by preventing the normal increase in flow in areas supplied by stenotic coronary arteries. So coronary arteries which are stenos, the blood supply will not go to there, wherever, because in remaining vessels, because of the vasodilation, there is no resistance, the blood will go into that coronary arteries. So this territory, the stenotic coronary arteries is the area which supplies, the area of myocardium supplied by the stenotic coronary arteries. It goes into the stress, and because of the stress, if they what we will check the response as you have seen in the dobutamine stress. Adenosine is a potent and short-acting direct coronary vasodilator. Dipyridamole is a slower acting, and its effect results from inhibition of adenosine uptake. With both agents, the development of a wall motion abnormality is predicted on the ability to create sufficient maldistribution. Compared to dobutamine, these changes tend to be more subtle and short-lived. Dobutamine stress echo, it is advantage is that it is readily available. There is no radiation exposure. it is more specific than SPECT, can utilize other predictors of viability such as LV wall thickness. Disadvantage is that image quality depends on patient factors, lower sensitivity, contraindication patients with tachyarrhythmias and uncontrolled hypertension. Going to SPECT. SPECT imaging provides reliable information on myocardial perfusion and to some extent is cellular viability. So basically this assesses the myocardial perfusion. So viability assessment can be performed either with 99M technetium sestamebe or technetium tetrophosphate or 201 thallium serum. So both sestamebe or tetrophosphate are transported passively into the myocyte and are sequestrated within the mitochondria. So tetrophosphine and sestamebe, they go and transfer passively into the myocyte and are sequestrated within the mitochondria. So these are taken up by the mitochondria. So uptake requires negative transmembrane potentials of sarcolemma and mitochondrial membranes. So if the tissue is viable, that is the sarcolemma or mitochondrial membrane, if it is viable, then only they will be able to take this sestamebe or tetrophosphine. Otherwise, if the tissue is dead, mitochondria will also be dead. Mitochondria also will be dead. So this tissue will not be able to take this sestamebe or tetrophosphate, and thus denotes the non-viability. However, the thallium-201 mimics potassium and is taken up by actively into the myocyte through the sodium-potassium ATPase. So uptake of thallium-201 depends upon the sodium-potassium ATPase, whereas sestamebe and tetrophosphate are dependent on the myocyte as well as the mitochondrial membrane integrity. So the uptake and retention of all the three traces is dependent on regional blood flow. So the regional blood flow is good, and the sarcolemmal membrane integrity is important for thallium because at sarcolemma there is sodium potassium ATPase, and mitochondrial membrane integrity is important for sestamebe and tetrophosphate. So areas with persistent little or no tracer uptake indicates so there is no tracer uptake. That means the tissue is non-viable myocardium. So rest only images demonstrate preserved or only mildly reduced perfusion are also indicative of myocardial viability. There are various protocols has been developed which are obtained from thallium-201 imaging is stress redistribution imaging, late redistribution imaging, rest redistribution imaging, and thallium-201 reinjection. So viability assessment with thallium-201 SPECT, that is single photon emission computed tomography. So thallium-201 behaves pharmacokinetically like a potassium analog. And this thallium-201 is an active sodium-potassium ATPase pump-dependent process. So it is present in the cell membrane. If the cell membrane integrity is maintained, the sodium-potassium ATPase pump will take this thallium. So the thallium-201 myocardial uptake is an indication of regional perfusion, which is necessary for tracer delivery. One of the important characteristic of thallium-201 myocardial uptake is its redistribution property. So this phenomenon was initially described in the late 1970s with reports of stress-induced myocardial perfusion defects that appear to normalize on repeat imaging at different time intervals. So this property is a consequence of constant exchange of the radiotracer between the myocardial cell, extracellular space, and subsequently the blood pool. So whenever a tracer amount goes into the myocardial tissue, so in between there is an exchange occurs between the myocardial cell and the extracellular space and the blood flow. From blood and myocardium, there is constant exchange of this tissue, this chemical which keeps occurring actually. So in areas wherever there is decreased perfusion, so suppose if a myocardium has taken uptake of this thallium, but if that at that region there is decreased perfusion or with diminished coronary flow, so what happens is that from myocardial cells, this coronary arteries and this blood supply will not be able to take this radiotracer back, and there will be persistence of this thallium 201 staining will be present in there. So thallium 201 extraction will be slower than in those with increase of normal blood flow. However, over time, what happens is thallium 201 continues in areas with diminished blood flow, whereas the radiotracer washes out from the areas with normal or increased initial blood flow. So if the blood supply is good from that area, there will be washout will occur, but remaining place there will be no washout. This constant redistribution of thallium 201 manifests on delayed imaging with resolution of the initial perfusion defect in areas. As thallium-201 uptake requires sarcolemma membrane integrity, resolution or reversibility of perfusion abnormality is considered to be myocardial viability. So initially, if there was defect, but later on, if there is uptake is happening, that means that area is maintained by myocardial viability. You can see here during stress rest, there was no uptake in this region, and after redistribution, like after if you do after later on after 24 hours or 3 to 4 hours, if you can see there is a more uptake of this area has been seen. So this is considered to be a viable tissue. Thallium 201 viability assessment protocols. You can take stress 4 hours stress test is 4 hours and 24-hour delayed redistribution protocol has been filled. So it has been seen that at 18 to 24 hours could improve the ability of the test to predict functional recovery after coronary revascularization. So late redistribution images are acquire a third set of images at 24 to 48 hours. This would allow for redistribution of the tracer to very ischemic tissue at viable tissue. Then with the 22% of fixed defects at initially can have later on will have a thallium tech can be seen. Okay, so standard SPECT images displays the short axis, which represents the anterior wall, inferior wall, lateral wall, and septal wall. So you can see here. And now, if you see this part, so you can see during this is infarct area. So this part you can see decreased uptake. That is the lateral part and the infralateral part. There is decreased uptake. You can see here even the posterior wall there is decreased uptake can be seen. So stress-induced ischemia you can see here. Again, there is decreased uptake. That means there is decreased intake of that. There is decreased viability of that tissue. So viability assessment with technetium 99 SPECT. Following the restriction from the blood, technetium 99 traces binds to the mitochondria, and thus there is results in negligible washout or redistribution. So there is no redistribution or washout occurs of technetium. So repeated scans, that is after 4-hour imaging or 24 imaging, is not required here. The advantage of SPECT is that it is readily available. It is part of a routine stress protocol. It is more sensitive than dobutamine stress echo. A disadvantage is that it has highest radiation exposure. It is all or none interpretation. It is prone to attenuation artifacts, especially in obese patients. Coming to PET scan, that is PET scan, which is a emission tomography. So it is FDG PET for viability. It is based on the fact that myocardium utilizes glucose for metabolism when under effect of ischemia. So normally at normal circumstances, normally for energy, myocardium uses fatty acids. But during the stress test or during ischemia, it utilizes glucose. Non-viable myocardium will not show any uptake. Non-viable myocardium will not show any uptake. Whereas if you give glucose, the infarcted, the ischemia part will take uptake. Ischemia part will take glucose will take an uptake. PET viability is unique modality in its ability to evaluate myocardial tissues myocardial glucose metabolism. So it assesses both the perfusion as well as the metabolic activity. At rest, healthy myocardium oxidizes free fatty acids to produce ATP. So at rest, normal myocardium uses free fatty acids. But in the setting of myocardial ischemia, there would be a shift of hibernating myocardial metabolism from fatty acids to glucose. So from the fatty acids, the tissue goes to glucose with upregulation of glucose transporter. For optimal FDG uptake of viable myocardium, it is crucial to stimulate endogenous insulin release. So FDG uptake. So suppose FDG uptake has to occur, there should be an endogenous insulin release should happen, and also you should maintain glucose levels between 100 to 140 levels before injecting FDG levels. Otherwise, there may be false readings may occur. PET imaging is performed after 45 to 90 minutes after injecting approximately 7 millisieverts of F18 FDG. Myocardial uptake of FDG continues to increase and blood activity decrease even after 45 minutes. Waiting 90 minutes after the injection of FDG may give better signal to noise ratio as the blood pool has less FDG. The typical scan duration is typically how much minutes? It's 10 to 30 minutes. So at perfusion tracer, you give perfusion tracer, perfusion imaging is done, then you give glucose there, manipulation, then you give glucose and you check for metabolic activity. So in patterns of perfusion, so because the PET assess both perfusion as well as the metabolic activity, if any tissue myocardium has a normal perfusion and normal FDG, it means it is healthy myocardium. Suppose if it is abnormal perfusion and abnormal FDG, that means it is presence of myocardial scar. Suppose there is abnormal perfusion and normal perfusion is abnormal, but if it is normal 18 FDG uptake, that means it is abnormal mismatch, or it could be because of hibernating myocardium where there is perfusion is defect, but the myocardium is still preserved. Unless it can be normal perfusion and low FDG uptake, reverse mismatch of adequately perfused myocardium metabolizing fatty acid rather than glucose. So this condition can be seen in if suppose myocardium is not using glucose but it is using fatty acids. So it will not use F18 FDG, then there will be low FDG uptake, whereas normal perfusion is maintained. So you can see here, here you can see there is perfusion is decreased in the anterior and as well as septum part, whereas perfusion decreased but metabolism is maintained here. You can see here metabolism FDG uptake is normal in that area. So it means that the tissue is viable. It can be seen in hibernating myocardium. You can see. You can see a scar tissue. There is no perfusion as well as no metabolism uptake can be seen. Here, inferior ball, you can see here there is perfusion is defective, whereas the metabolism is maintained. It can be seen in hibernating myocardium. So, if perfusion is preserved, glucose metabolism is preserved, that means tissue is viable. If perfusion is reduced, glucose metabolism is preserved. That means it could be either mismatch, mainly seen in viable hibernation. If both are reduced, it is non-viable. If perfusion is preserved but the glucose metabolism is reduced, that means it is reverse mismatch. You can see here again, there is mismatch defect in the lateral wall. So uptake of metabolic activity is present, but perfusion is not there. Coming to cardiac MRI, two methods of viability as testing by cardiac MRI. Cardiac MRI can use we can use either for contractile reserve assessment using dobutamine stress MRI. And you can check late gadolinium enhancement imaging using gadolinium based contrast agents, with the latter being the more common and preferred technique. Latter being the more common and preferred technique is used in these cases. So there are two methods of viability testing by cardiac MRI. One is contractile reserve assessment and the late gadolinium enhancement. So gadolinium-based contrast agents are paramagnetic metal compounds that, when administered intravenously, so if you give intravenously, they will cannot penetrate the intact myocardium tissue. So this contrast agent of the MRI cannot penetrate the intact myocardial sarcolemma. However, if the tissue is dead or tissue is necrosis or scar, that this can go and deposit it in that part. So GBCs are used to index cell membrane integrity, as living myocardial cells will exclude GBCA when steady state concentrations are reached. In an acute myocardial infarction, GBCA passively diffuses intracellularly. In chronic infarct, GBCA concentrates in collagenous scar that has replaced necrotic tissue. So in infarct tissue and scar tissue, this contrast will be taken, and you can see that late enhancement can be seen. So also evaluation of resting function and wall thickness. Preserved myocardial wall thickness of more than 5.5 mm has a good sensitivity of 95% but low specificity. And another important thing is end diastolic wall thickening of thickness of more than 5.5, and with systolic wall thickening. So with systolic, if there is more than 2 mm increase in thickness, that means that it is viable tissue. Late gadolinium enhancement is best observed 10 to 15 minutes after contrast injection, when difference to normal myocardium are maximized. Clinically, gadolinium-based contrast agents are distributed into the extracellular space following an intravenous injection, and you can see the myocardial scar and focal fibrosis can be seen. If the extent of scar is less, as indicated by less than 50% transmural extent of hyperenhancement, indicates viability. If less than 50% of transmural extent, that means that this tissue is viable and you can do some intervention there. If 4 or more dysfunctional segment shows viability, 4 more dysfunctional viability, it has a good sensitivity with low specificity. So this is without infarction, 1 to 25%, that is viability is preserved. 26 to 50% viability is preserved, and if it is more than 50% of the transmural tissue is gone, that means it is infarcted, viability is absent, and there is no use of doing reperfusion in this setting. Advantages of cardiac MRI is high quality of images, absence of ionizing radiation, high prognostic value, lower cost relative to nuclear imaging. Disadvantage is that the need for gadolinium-based contrast injection, which although generally safer than urinary contrast injection, can cause allergic reactions, but can still cause allergic reaction and anaphylaxis. And late gadolinium enhancement shows the expansion of the extracellular matrix. So not only the extracellular, but it can go also bind to the collagen, water, or amyloid. It can go bind into that as well. So it can give rise to a false positive reports. Dobutamine stress CMR is the same as dobutamine stress echo, where you do infusion of low dose dobutamine at 5 to 10 micrograms per kg per minute. Improvement in myocardial thickening of more than 2 mm is considered to be viable. In addition, low dose dobutamine can accurately predict the development of adverse remodeling following acute MI. With high dose dobutamine, the presence of indivisible wall motion abnormalities using cine CMR can trigger a biphasic response. Combined use of low gadolinium enhancement and low dose dobutamine stress CMR has a high specificity and lower sensitivity according to meta-analysis. So advantages of our cardiac MRI is high resolution imaging, high sensitivity and specificity, no radiation exposure, evaluates transmural extent of scar and gold standard, non-contrast viability methods, and simultaneous evaluation for other etiologies of cardiomyopathy. Disadvantage is that it is less availability, higher cost, image quality dependent on ECG getting and breath holding. Contraindicated in claustrophobia, certain metal objects, and advanced renal disease.